Good evening, everyone. We are so glad that you joined us. My name is Ray Blaylark, and I am the president and CEO of Sickle Cell Foundation of Minnesota. Tonight, we are so excited to have an incredible town hall. We've opened up our space as the Sickle Cell Foundation of Minnesota to have this larger conversation. Before I get into that, let me just first make sure that I say thank you to our partners and sponsors. Of course, the Minnesota Rare Disease Advisory Council with Erica Barnes, Beam Therapeutics, Memorial Blood Centers, and I always like to make mention that sickle cell disease data collection program through the CDC. Minnesota is one of only 11 states that are participating in that program right now, so we're very excited. We want people to know that we are leading the charge on data collection around sickle cell disease here in Minnesota. So without further ado, let me stop sharing for just a moment. Oh, you know what? My always disclaimer is we do this show live, so none of us are perfect. So I'm going to share again because there's something I want to make sure of. I want to make sure that those who are here know that we are here with the Minnesota Rare Disease Advisory Council. We're having a rare town hall. So we are excited about that. The video will be uploaded to our YouTube channel in about 24 to 48 hours so that you too can see it. And there we go. So we are at SickleCellMN on YouTube, and you can see that video, the replay on demand at any time, your convenience. We also ask that you share it with others who may not have been able to make it today. So back to what I was saying. We are in for a treat. The state of Minnesota has a rare disease community, and that community falls under the umbrella of the Minnesota Rare Disease Advisory Council. We're going to learn so much more about what they do, how diverse this community is, and what can ordinary citizens do to really support the rare community. And even more than that, the diversity of the rare community. So we're excited to talk about it. Now, this is a community conversation, right? So there's a Q&A button down at the bottom of your screen. If you're on your phone, you might have to click on the little 3 dots or however it looks on your phone to get into the options, but it is there. We invite you to use the Q&A button for any questions, and we invite you to just chat and in general conversation, make a comment, good point, all of those things right there in the chat window. And we'll take a look. You don't have to wait till the end of Erica's presentation if you have questions. That's what a community conversation is all about. So without further ado, I want to introduce you to someone who is a colleague, but she's also a friend. But within this rare disease space, she's always been welcoming to the sickle cell community, and she's always been an ally and a champion for the work that we are doing in sickle cell. So I'm going to turn it over to Erica. Erica, the floor is yours.
Thank you so much, Ray. Thank you for inviting me. And I want to just say, Ray, could you sort of monitor that chat? And again, I'll repeat what Ray said. Please feel free if you have questions throughout my presentation and my talk. This is a town hall, so I wanted to feel very participatory. So if you have any questions or comments, clarifications, I'll look to Ray to kind of call those out so I can stop talking and answer those questions. Otherwise, I'm hoping we have some good conversation at the end of the presentation. So give me just a second to share my screen here. Can you see that, Ray? Is that visible? Great.
Looks good.
Fantastic. So I'm going to get started. The presentation I really wanted to, it is about the Rare Disease Advisory Council. So again, as Ray said, my name is Erica Barnes. I'm the Executive Director of the Minnesota Rare Disease Advisory Council. A little bit about myself. I started out my career as a speech language pathologist working in the hospital system. So I was working in that capacity, and then I actually had a child who at the age of 2 was diagnosed with a rare disease. The experience of accessing care for her was difficult, and she eventually was diagnosed with a rare degenerative neurodegenerative disease, and she sadly passed away. At that point, I really jumped into advocacy initially, and this will be kind of the theme of the talk, initially really focused on supporting that specific rare disease community, the MLD community, metachromatic leukodystrophy community. And then as I started my advocacy work, I really started to see that the barriers that I faced and that my family encountered were being replicated over and over again. And what was common was these rare disease communities. I started to see these themes. So I embarked on the journey of really advocating not only for metachromatic leukodystrophy and progress in that space, but for the entire rare disease community. So I will certainly talk about the RDAC, but I also want to really stay focused on the community, what the rare disease community is and why it matters to specific patient populations. So just give me 1 second. There we go. Oh, got a little too excited. Okay. So first of all, and forgive me if some of this is review for some of you, but I wanted to just kind of level set a little bit of rare diseases. What are the facts? What are the facts and statistics about rare diseases? Obviously, if you are brand new to learning about the rare disease community in general, it would be understandable that you would say, oh, a rare disease, it must only affect a very small percentage of the population in the US. And of course, that's true individually. So single diseases are defined as rare if they affect fewer than 200,000 individuals at any given time. This is an FDA definition, so that's who kind of established it. It's a pure prevalence definition, right? It doesn't tell us anything about the diseases themselves. So on its surface, it's a very straightforward definition, but as we go along, you'll see that it gets a little more complex. There are roughly 7,000 rare diseases. I think actually now we're really looking at upwards in the 10,000s, I think is the new statistic that I recently heard. And these are diseases that span all biological systems. You could have a rare skin disease. You could have a rare neurological disease. You could have a rare blood disease. So there's a lot of heterogeneity and variety. But at the same time, they're not so rare. Even though there's lots of different etiologies of the diseases, one of the more commonalities we see is that about 80% of rare diseases have a genetic basis. There's a genetic component to a lot of these diseases. So the way that genetics has expanded and our understanding of genetics in recent years has a lot of implications for the community. Also, the majority of these rare diseases have a pediatric onset. They start right away for individuals, and the vast majority are chronic and they are medically complex. So these are often difficult diseases to manage and have a large impact on the communities. Collectively, they affect 8 in 10 of the general population. So individually rare, collectively common. And so what exactly do I mean when I talk about the rare disease community? And I think that it's really important, and the reason I'm so glad that we're having this conversation, and I'm glad that Ray invited me to talk about it, is, it's so important to define a population, because I love this quote. This is actually a quote by the gentleman who came up with the triple aims of healthcare, for those of you who are familiar with the triple aims of healthcare. And this quote really struck me when I read it for the first time, that only when a population is specified, so when you can define that population, does it become possible to know about its experience of care, its health status, and per capita cost of caring for it. So you really have to define a population before you can start any kind of improvement and any sort of addressing the needs of the community. So surprisingly, and I won't go too in depth in this, I'm kind of a history geek, so I will try not to get too in depth with this, but surprisingly, when I started really thinking about the rare disease community, the idea even of the rare disease community collectively is very recent in our healthcare system. If you look for the term rare disease, if you look for the term rare disease community, you're not going to find it in the medical literature, certainly not as a sociological kind of construct. You really find the term rare as it defines sort of a rare skin disease, rare cancer, but you're not seeing it as a collective category for multiple diseases until the Orphan Drug Act in 1984, 1983, 1984. The other thing I want to talk a little bit about is a lot of times you'll hear the terms orphan disease or rare disease. And so I wanted to talk a little bit about why the term orphan disease has been applied to the rare disease community. So there was a pediatrician who penned an editorial in 1968, and he used the term therapeutic orphans. And that was a term that he used to describe basically neglected diseases that didn't have drug development. So he initially applied it to the pediatric population, but that term has been used to describe diseases that don't have any therapeutic options. They're orphans in our healthcare system. They don't have a family. But the community really began to identify as a population and start to work collectively, primarily with the idea of passing the Orphan Drug Act. This was led by Abby Myers. She was a mom whose son had Tourette syndrome, and there was no treatment at the time except something off-label. And when the company discontinued that drug, she began to advocate for more work at the FDA to support the rare disease community and to come up with treatments. So starting with coalescing around a grassroots effort to get the Orphan Drug Act passed. And then she went on to found the National Organization for Rare Disorders. So I'm very proud of our community, and you should be very proud of our community if you belong to it, in that, you know, the formation of the rare disease community, it was primarily a patient and advocacy driven term. The advocates drove this creation of our community. And then the definition was more firmly established by the FDA when the Orphan Drug Act was passed. And I have this visual to sort of show you the evolving relationship in our health system and in the landscape of our healthcare system. So before the Orphan Drug Act, we see a lot of fragmentation in the rare disease community. There was really no recognition of the rare disease community. A lot of fragmentation in patient populations and advocacy efforts. So lots of rare disease communities potentially working on things, but doing it absolutely in silos and absolutely without knowledge of each other's work. Prior to the Orphan Drug Act, there were only 38 FDA approved treatments for any rare disease. And remember, we're talking 7,000 rare diseases. So prior to 1984, there were about 38 treatments that could be applied to a rare disease community. Then we had the passage of the Orphan Drug Act, and that's where we saw that patient advocacy community really take off. And it was the passage of the Orphan Drug Act where the FDA really started to provide some incentives for drug companies, that we saw an uptick in the approval and the amount of approved FDA treatments. As of 2021, we had almost 600 rare disease treatments. That number is exponentially growing. So some real progress. But really want to focus on that right side, the rare, what's left to do. So we know that there's been a lot of progress in the community, but also the rare disease community, we need to continue to make progress. And the big area of progress, from my vantage point, is really helping the healthcare community to recognize us as a distinct subset of the healthcare population with a very distinct set of needs. And I'm going to dive into that more deeply on the next slide. But one thing that has struck me over the years is really, as I engage with different patient populations, really seeing some of the same barriers to access when the rare disease community seeks to access care. And as I move into that talk, this is where I want to really start to engage people that are listening. If you've tuned in and you belong to a patient population, really engage how much these observations and some of these findings resonate with your community, and be thinking about some cross communication. How can we really work together to address some of these challenges? So I gathered this slide, and as I was making it, it really struck me again that even though the takeaway from me right now is that the Orphan Drug Act ensured significant progress in drug development and in some policy, but the rare disease community really has a lack of integration into our healthcare. And I'll talk about that with some survey results. And it's really resulted in some healthcare disparities. And if you are anything like me, and you've kind of got your radar up for, the rare disease patient populations, there's no shortage of news stories now coming out about the rare disease community. And these are just 3 headlines that I pulled from the last few years. So NPR has run stories, the Chicago Tribune, and the New York Times. And if you read some of the subtext or the subtitles of some of these, you really start to see some striking gaps in care for the rare disease community. So that first top one was a series of stories that the New York Times ran a couple of years ago. And they talk about, that some of these families, they highlighted 4 families that were confronted with diseases that science has overlooked, and the families had to find their own approach to treatment. So starting their own pharmaceutical companies, raising millions of dollars. You look down at that screen, the families that have raised millions of dollars for treating genetic disorders, and yet still they're waiting for a cure. I'm really struck with, the first thing that comes to mind when I look at that bottom NPR headline is, the onus to raise so much money. Who does that leave out? Who does that leave out for treatment? Who does that leave out for being able to have their child cared for? If the expectation is that in order to get your rare disease treated or any attention, that you would be expected to raise millions of dollars. Then the other issue, a headline, and this is actually a little boy that I know from my own community, being able to access treatment across state lines, or being able to access treatment outside of your geographic area. How often are patients able to access the treatment that they need, knowing that rare disease patients have to travel for their care? So while we've made progress, there's really a lot to do still. And I wanted to give, and so to kind of dive into that a little bit deeply, this first slide I'm going to have is really some overall statistics that we know. Some of you, again, these may be statistics that you already know. And then I want to dive a little bit more into some Minnesota specific data that we got from a survey. So the lack of visibility in the healthcare system is really illustrated by a number of statistics and a number of figures. So the very first thing, if you look on that right side of the screen, the very first way that we have lack of visibility in the healthcare system, I think it starts in medical school. There's an old adage, and this is why we use the zebra, by the way, as a community. There's an adage in medical school that says, when you hear hoofbeats, look for horses and not zebras. And it's a very well-intentioned phrase that's really the purpose of the phrase is to get medical students to not kind of chase after a rare diagnosis when the overwhelming likelihood is that they're looking at someone with a common disease. The problem with that, of course, is will you miss the zebras if you're just looking for horses? So that's sort of from the get-go, in my opinion. Again, I understand that the well-intentioned behind that phrase, but the bias that it sets up for being able to even identify rare disease patients is just very real. I was at a conference for physician assistants, and I asked in the room how many of you were told this phrase in your medical training, and every single person raised their hand that they had heard this phrase. The next way that an indication that there's a lack of visibility in our healthcare system is the fact that there's only 500 ICD-10 codes. So that the ICD-10 code is the way that you code a diagnosis in the healthcare system. And even though there's 7,000 rare diseases currently in ICD-10, there's just 500 codes. So even having that show up in a healthcare system, having those rare diseases show up, we can just see the disparity there. 7 to 8 years to diagnosis, 2 to 3 average misdiagnosis for a rare disease patient, and an average of 8 clinician visits prior to a diagnosis. Again, just these are outcome disparities outside of common disease and all the issues that someone with a common chronic condition would have. Something that we found on our survey is that rare disease patients are traveling an average of 60 miles to get to care, which again is much further than the average patient. And then only 5% of rare disease patient populations have an FDA approved treatment. So those are just some very general statistics that are pretty well known. And then the Rare Disease Advisory Council did a couple of different of our own surveys. So one of the very first things that we did when we were established in 2019 was to do 2 surveys. One survey that we did surveyed the rare disease community. And the next survey that I'll show you, we surveyed the clinician community, the medical community. We know that both rare disease patients and individuals providing care face their own set of barriers. For the sake of time, because I promised Ray I would try to stay within my time frame, I am not going to go really in depth. I'm going to pull out some of the highlights, but you can find infographics and surveys on our website, and I'll give you the website link at the end of my presentation. You can find more information on these surveys and do a little bit of a deeper dive if you want to. But with our patient survey, we found a number, again, some of these are just kind of confirming what we sadly already knew, and then we found some new information. So the first thing that really struck us with our survey was the lack of access to specialists due to networks. So people reported being initially denied seeing a specialist due to out-of-network issues. 27% of the pediatric population reported that, and 19% of the adult population. So obviously that's roughly a quarter of rare disease patients having difficulty even just accessing a specialist who could diagnose or provide care. I am very proud of the state of Minnesota, and I'll talk a little bit later. I'm very proud that our community worked on some legislation in the state of Minnesota to change that, so that if you have a rare disease, you can go out of network and see the provider that you need to see. But that is definitely an issue that has been ongoing. So I'm very excited for the state of Minnesota to try to change that. The next thing that we found is significant delay to diagnosis. No surprise, right? If you're not getting it to a provider who knows anything about your disease, you are likely waiting a very long time. So well over half waited for over a year and up to 10 years to receive their diagnosis. Again, you can look at the survey data and see the breakdown of that. Lack of access to treatments considered investigational. So once again, knowing that there's only 5% of FDA approved treatments, the ability to access any sort of treatment is a barrier, and there's just a lack of access to some of these investigational treatments. We know that there's lots of treatments coming down the pike for rare diseases that are in the pipeline. Hopefully those will get FDA approval, and we can see many more treatment options. And then this one is really this bullet number 4 is something that we've been dealing with and trying to address as a council. Significant difficulties when transitioning from pediatric care to adult care. And I know this will resonate with some of you likely on this town hall, but we found that being able to transition care was incredibly difficult. 44% reported problems with that transition. And then insufficient education from general care providers. And we know that this is difficult, right? Finding credible information sources is difficult. So the patient community was really feeling that, not really being able to get the information that they needed from their general care providers. Around 21% were having difficulties. Again, Ray, feel free to interrupt me if I need to just pause and take a breath. I know I've been talking for a long time, but
I'm coming back on camera.
You're just waiting for me to breathe.
No, you're doing a great job, because I think that what's important is that, the rare disease community is so large that sometimes we can easily lose sight of, number one, just how large it is, and then those who don't have the same level of access. Now, we know the whole rare disease community is impacted by these things in some way, shape, or form, but then you have, depending on what the issue is, that's where you get all of this diversity that comes together to really talk about where these gaps are happening.
Yeah, that is so true, Ray. And I think, not to kind of get off topic, and I will talk about this more on a slide, but even thinking of that intersectionality, right? Of you've got these barriers in the rare disease community, and then what if there are social barriers that get transposed, right? So when I see that, how far people are traveling for their care.
Yes.
What about communities that already have difficulties with transportation, right? And so these disparities in healthcare put up against the social disparities, what communities are being even more impacted.
And we're going to talk about that, as you once you wrap up your presentation, we're going to talk about that, because access is not just about, transportation. It's not just about there is a center near you. It's so much more than that. So we're going to talk about that a little bit.
Good. So that's the patient survey. And like I said, that survey was huge. We had over 1,100 participants. It's one of the largest surveys ever done in the US on the rare disease community. I think people had time on their hands during COVID. So I'm very thankful that we got all that data. So I really urge you, go to the website, take a look at some of that data, because there's much more. I couldn't possibly cover all of what we found out from the community. The next survey that we did, as I said, was a survey of the frontline providers, or the clinicians. And again, we really wanted to compare, okay, what are some of the challenges that the rare disease community is facing when they're trying to access care, and then what are challenges of physicians? It's our goal as a rare disease advisory council isn't necessarily to ask clinicians to do more. We know they're doing a lot, but we are asking that they think differently about our patient population, and how can we understand where the gaps are and where the challenges are, and how can we provide resources for the medical community. And again, lots of telling information. You can go online and look even more in depth at our infographic and our information. But what we found was a quarter of physicians reported that they didn't feel they had knowledge to meet the needs of their practice of the rare disease community. So a quarter of physicians said they didn't know enough about rare diseases. Again, kind of comparing this with what the patient community was facing in terms of transition of care. 60% of clinicians said they have difficulty with that transition of care process. And of that 60%, 56% of the respondents said it was because a local provider was unwilling to take a patient. That is a big pain point. We know it's very difficult. So we're doing some work in transition of care. Another thing that was very interesting and very telling from the survey is that 75% of clinicians reported that they were only somewhat or not at all comfortable interpreting genetic tests. Recall that on the slide before, we talked about 80% of rare diseases being genetic. So again, if we are looking at genetic testing, which is certainly, advances being made in genetic tests, but providers and clinicians just not having the comfort level to interpret those genetic tests. What are the implications for the rare disease community? And then 90%, and this was actually encouraging and exciting, 90% of the respondents said that they would benefit from further education about rare diseases. So as you can see, the medical community also has their own set of challenges when trying to meet the needs of the patient community. So then having that data, one of the things that I want to talk about, and one of the things that I think is so important, and people have asked me, frankly, medical professions have asked me, Erica, what's the utility of thinking about the rare disease community collectively? Why does it help me serve my patient population, or my patient in front of me? What is it? And one of the things that I really try to say is, really thinking of how your patients are impacted. If someone has a rare disease, what are some of those things? What are some of the barriers that they're going to face? And even if we think about it through, if you think about social determinants of health, and the kind of the twist for the patient population is we experience this a little bit differently, right? We experience social determinants of health. We have to think of them a little bit differently. And I always tell clinicians, you know, if you tell me that you are seeing a rare disease patient, somebody who's been diagnosed with a rare disease, I can probably tell you some of the impacts and some of the barriers that they face sight unseen, just by the mere fact that they have a rare disease. So the first kind of thing, if you're thinking about social determinants of health, where we live, so geography, but it's a twist, right? So invariably, rare disease patients have a geographic challenge to get to the care that they need. There is probably a geographic disparity. There's probably no one within their radius who can provide the care that they need. They're probably traveling, if not across the country, at least across the state. And then, of course, if there's no treatment, there's no access. No matter where they travel, they're not going to be able to receive the care they need. So there's this inability to find care in their local community. A fair amount of rare disease patients relocate in order to receive the care that they need. They may relocate from another state to get to be near the specialist. They may relocate to an urban area to be able to get access to the specialties that they need. So that has implications for our greater Minnesota. Also, I think of health literacy. This is one thing I think a lot about, and Ray and I have actually talked a lot about this. You know, health literacy for our community is difficult, not because of our own, educational levels, but because of the lack of information out there. So very often when we talk about rare diseases, there's no published information about a rare disease. We don't have access to education about the disease to educate ourselves so that we can care. I always tell the story about when we were seeking a diagnosis for my daughter, and when she was first diagnosed, the only place I could access information were medical journals. And I was frantically texting anybody I knew who might have access to these medical journals. But again, I know I raised this earlier, and again, Ray and I talk a lot about this. Who does that leave out in terms of being able to have health literacy and information? If the only place you can access information is a medical journal, what patients are not receiving the education that they need about their rare disease. Another issue here is often there is no credible source of information. There's no patient advocacy group. I saw a number quoted, and I'm going to throw it out there, but I don't have it verified. But I did see on a website that only about 15% of rare disease patient populations have a 501c3 dedicated to advocacy and education for their rare disease. Of course, there's the National Organization for Rare Disorders, there's Every Life Foundation, but in terms of a patient community having a dedicated patient advocacy group. So imagine the cancer community not having the American Cancer Society. That's what rare disease patients face, just a lack of education. Often we access our information from Facebook or social media. That can be fantastic. It can also be a double-edged sword. While Facebook and some of the social media is wonderful for connections and a source of information, it can be also a source of misinformation. So health literacy is a big issue for our community. And then social supports, the isolation that patient communities have. Nobody looks like them in their community. And then a lot of trauma from delayed diagnosis or delay in treatment. So medical trauma just coming from not being believed in the healthcare system, not receiving answers, and really having to be their own advocate. Stigma and judgment. Again, if people don't know about your diseases, I know I've had so many rare disease patients tell me I'm constantly educating not only people around me, but also the medical community, because there's just not a lot of knowledge. I'm going to pause here again and take a breath. For those of you who are tuning in who might belong to a rare disease community and identify with a patient, disease-specific patient population, I'm just wondering what resonates with you and your community. What about either the survey or the social determinants of health? Do you say, yeah, that really resonates with me? Or maybe you're looking at this and you're like, wow, our community is doing better. You know, we have a patient advocacy group, or we have access to education. How many are saying worse, you know, than some of these statistics? Maybe there is no specialist. Yeah,
one
Ray.
of the things I love about this slide is that there's so much overlap from community to community. I think it's so easy for us to operate as silos, according to just our singular condition. But how important it is to understand that when we interact and we engage with other groups, other rare groups, other rare individuals, we find that we have much more in common than we think. But we have to take ourselves out of that box that we sometimes either get put in or put ourselves in to say, because rural versus urban is an issue for all conditions, right? And particularly rare diseases who already don't have enough expert providers, right? So when we talk about that access, access is like this blooming onion, right? You know, and the more that you peel back the layers, the more you see more layers, because it impacts every piece of your life. I often call rare conditions biopsychosocial, because it impacts every part of your life and in turn impacts your quality of life. If you don't have a car, whether you live in the urban area or a rural area, getting to your appointments. If you miss appointments, if you have multiple children, you have a number of things happening, you can't get time off of work, you're worried about losing your job. You know, now you have to deal with the stigma of, you know, not being the ideal patient. When it's really not about you not being ideal, and it's more about the determinants that you had to address in order to come in, and the pieces don't always fit together. So I can appreciate this particular talking point, because it is important that we focus on what we share from community to community. Where's the overlap?
Yeah, that's so good, Ray. And again, sort of, I know I said it before, but again, going back to, you know, which communities are sort of experiencing this double hit from the geographic challenges by simply having a rare diseases, having the challenge of accessing care, because the geography or the transportation issue, and that really doubly impacting communities. But you're right, there are so many shared barriers across these rare diseases.
Yeah.
So what can we do? What can we do to improve the care for the rare disease community, and where does that leave us? I definitely, there's a lot of challenges, and it can be overwhelming, but there's a lot of hope too, and there's a lot of ways that we can improve care. And so I definitely wanted to spend some time sort of talking about that. And this is where the Rare Disease Advisory Council comes in. So the Rare Disease Advisory Council exists in the state of Minnesota to be able to really represent the rare disease community. So the Rare Disease Advisory Council, for those of you, I'm looking at this picture, it's one of my favorite pictures in the entire world, and I'm sure there's some of you on this town hall that are in the picture. This is a picture of the governor signing when the Rare Disease Advisory Council passed in 2019. So the Rare Disease Advisory Council was truly formed by a grassroots coalition, about 42 members. It was patient advocacy organizations, medical associations, hospital systems, industry partners, and we all came together to say the rare disease community is a subset of the patient population in the state of Minnesota, and we need representation. In 2022, we transitioned to our own state agency that gives us much more of a mandate and much more of an opportunity to address some of these systemic policy issues in the state of Minnesota and truly be a leader. Our vision is a state where every Minnesota citizen living with a rare disease has access to timely diagnosis, coordinated care, individualized treatment and management, and support across the lifespan. We really have three buckets as a state agency and as a council that we're building out, and three sort of areas and aims that we have that we are working on. The first one is to be a comprehensive policy and information resource for the state and all the stakeholders, whether that be a state agency, whether that be a committee within DHS or MDH, whether that be the state legislature, but being a comprehensive policy and information resource for all the stakeholders. The next kind of aim and bucket is support and equipping the medical community to better address these unique needs. So we talked about that, those unique challenges, and really focusing on the unique challenges over and above what any individual would face when they're encountering the healthcare system and seeking to access healthcare in the state of Minnesota. We really want to address the unique needs that we mentioned, to reduce those health disparities that are so way off and way beyond where they should be in the rare disease community. And then, of course, last but absolutely not least, we want to support and empower the rare disease patient community to advocate for improved quality of life, really supporting patient advocacy groups and organizations and bringing people together, convening and helping patient populations more quickly be able to accelerate research and get to a place where they can be more mature as a patient community and advocate for themselves. And I could go on and keep talking about the Rare Disease Advisory Council, but I'm going to mention some of our accomplishments, and then I really want to engage. I want to spend the rest of the time really hearing and really engaging with all of you. Some of the things that we've accomplished thus far is, as I mentioned before, this year, the passage of we supported and advocated for the passage of the Network Access Bill. That is a bill starting January 1st of 2024. Anyone in the state of Minnesota with a diagnosed rare disease can access the specialists and the care that they need regardless of their insurance status, network status. The goal of that is to really address that delay in diagnosis. We know that one of the salient features of our communities is that diagnostic odyssey. So our aim and our goal is to get people to the appropriate care. Secondarily, of course, to do better care management. We know that it is self-evident that you are managed better and your disease is managed better if you are seeing someone with knowledge of your disease. So the goal is to make sure that rare disease patients are getting to competent care. The RDAC was also added to 2 committees in the state of Minnesota. We're very excited to be on the Drug Formulary Review Committee. We know that what's common sense for common diseases is not always common sense for rare diseases. So as the state is making considerations about where the treatments that we do have, where they're placed on the state formulary, and what kind of prior auth procedures, we really want to make sure that we have a voice as a community and we're not left out of that conversation, and the unique barriers and the unique considerations have representation in the state. And then the next thing that we're doing that I'm very excited about, and again, this really flows out of all that information we were seeing on the difficulties with transition of care. We're collaborating on a learning collaborative, actually, that also a component of that is an Project Echo that Gillette Children's is hosting and building out. So for those of you who don't know, Project Echo is a telementoring program, and the goal is really to take specialty care and specialist people with specialized expertise and make that available to other clinicians. So it's a telementoring tool that'll be starting in September. I urge you, if you're interested as a clinician, or if you're a patient community who would like to educate your clinicians on transition of care, to go to our website. We'll be posting more information as that Project Echo gets off the ground. The first one will be in September. So I urge you sign up for our newsletter. We'll be sending out information. Another project that we're embarking on is we will be collaborating with the state of Minnesota's all payer data claims team. to just determine this sounds very basic, but it is information that's missing. Rare disease prevalence in Minnesota. How many people truly in Minnesota are living with rare diseases? Is that 10% number accurate? And really, that's just the start, really working with different agencies, especially the all-payer data claims team, to really start to set a baseline. I know Ray's probably going to smile. Some of these phrases that I say to my council a lot, if we can't measure it, we can't improve it. And so often in the rare disease community, we don't even have just baseline measures. So really working with the state of Minnesota to get some of that baseline measurement. So those are just a few of the things we've accomplished. Again, I'd love for you to contact us. Our website is here on this screen, and you can go and see more accomplishments that the council, more initiatives that we've been working on, and then sign up for our newsletter. And also feel free to reach out to me and send me an email with any questions. And so, Ray, with that, I'm gonna turn it over to you to take us into the next phase of this town hall.
So that is excellent. There you gave so much information that is so critically important. And I'll just say this, even though we're doing this in our state, similar types of work are happening across states, but particularly those that have some sort of a rare disease advisory council. And so if you're from a state that has it, I encourage you to look into who's running that and how you might get some of this same information. If you're in a state that doesn't have it, who can you partner with, right, in order to make this happen? Because that's how things move forward. We have to operate collaboratively, and we have to develop a coalition that addresses this broader community, so that the trickle-down effect of the benefits affect more people and not just those in a silo. So I love it. We have one question that's in the Q&A box, and I think it's a great question. Do you envision the creation of a rare disease patient registry?
I am really glad to have gotten that question. That is definitely something that the council has been exploring. We have been, patient registries are absolutely, in my opinion, an absolute essential for any patient community, disease-specific community, really starting a patient registry. I encourage every rare disease community to start a patient registry. Now, we could do a whole webinar just on patient registries, right? Because that term is used in many different ways. You can have a contact registry. You can have, a registry that has biostatistics, but and kind of functions like as a natural history to help understand the natural history of the disease. But I definitely say that, first of all, I encourage patient communities to start registries. If you are a patient community and do not have a registry, the council, I can help, and the council can help advise that. We have been looking into the possibility, we've been looking with a couple of partners about the possibility of having a Minnesota rare disease patient, Minnesota specific registry for anyone with a rare disease in the state of Minnesota. So that is something we're looking into for the next year. And so the short answer is yes, that might be something that we do as a state. And also every patient community should, if you don't have a patient registry, think about getting started on something like that.
That question is so good, and I'm going to take it one step further. What about a rare provider network, right? How we know that there's a shortage of experts. I call them rare providers because they really are rare, right? Just
Yes.
as our conditions are rare. It's difficult to find someone in your area who is an expert, has some expertise, let alone if you have to go outside of your state and try to identify someone. That just kind of adds to this odyssey that people are on. And it's not, yes, the diagnosis is one piece. I think about the sickle cell community, even though our diagnosis, and we are blessed that it happens at birth, right? Even though many do not get diagnosed, as you said, that odyssey can take years. But even when it's time to transition, you know, that's one of the major issues is who are you transitioning to? And are they embracing you or are they tolerating you? You know, do they have the answers or do they have at least the wherewithal to partner with you in the journey to better understand your condition? Or, you know, there's so many different approaches that don't feel like that we're being engaged in our humanity. And so, you know, I think that being able to have some sort of a provider registry is helpful also.
Yes, thank you, Ray. And that is another initiative of the council that we'll be embarking on. We're referring to it as a clinician directory, because registry just has such a specific, you know, specific term, but I couldn't agree with you more. And we know another thing that we know about the rare disease community is that rare disease patients often are accessing care in different healthcare systems. They're not staying in one healthcare system. So the ability to have a directory whereby physicians can find one another across the state, across systems in Minnesota, that's so vital for the community because it's difficult, especially with these rare complex diseases. Again, you may have a specialist who understands, you know, a hematology specialist over at, you know, one of our healthcare systems, and you may also need to see a neurologist at a different healthcare system because they have this very specific knowledge.
And that fractured care isn't helpful, you know, to outcomes.
I say we're a fragmented community and a fragmented health system, right? Our fragmentation is so you're right, Ray. So having those tools whereby we can at least start to coordinate and communicate with one another.
So I love it. There's another question that came in, but I want to ask this question. If you are a person who is a member of the rare community and you have a rare condition, how do they support the Minnesota Rare Disease Advisory Council? What does that look like to the average patient who's living with a condition? So in the next, so we had our first patient listening session here last week, Ray. I know you were in attendance, and you know, one of the first things I can say to get involved is you know, reach out to me, contact me. We're going to be starting. I want to hear. My first thing is, you know, this is a very heterogeneous community. So if you have a rare disease, I may not have ever heard of it. So the first thing you can do to help us is educate me and reach out to me. I appreciate people so much, communities reaching out to me. We're going to start building out a resource list of, we want to have a list of all the patient advocacy groups that are operating in the state of Minnesota so that we can start directing patients to those rare disease specific patient advocacy communities. So letting me know about the community, and then staying tuned for, we're going to have Advocacy Day coming up in February. So we're in the midst of planning that. We're going to be doing some workshops for patient communities. Another thing about the rare disease community is what I've found is you know, patient communities want to get involved and want to advocate for improved policies, but often rare disease communities are overwhelmed and just trying to take care of themselves and take care of their loved ones. So the council really wants to provide that resource, that collective resource of collective advocacy. So getting involved in policy priorities and then planning for Advocacy Day. Yeah, we talk about that a lot, is, you know, getting together as a rare community. So it's so encouraging to hear that, you know, we are moving in that direction, because I think that we are more effective together than apart. You'll hear me say it constantly. We don't need to be in silos. Silos don't make change. They don't. Okay, so another question, and I do think this is a good question. This goes back to access and capacity family capacity. So how are caregivers navigating these high costs of rare disease therapy, travel, and just the general cost of care?
Yeah, one of the surveys that we have posted on our website under our resource page is the Every Life Foundation did a burden of rare disease study, and just really showing the burden and the cost on families for trying to care for these rare diseases. It's very intense. And so the survey again found, and our survey, I think one of the most telling, and I can't believe I didn't put it on the slide, so I'm glad this question came up. One of the most interesting findings of our surveys, and the most sobering for me, was that rare disease patients are scoring lower on the PROMIS score. So that's a normed, I'm not sure what it stands for, but it has to do with quality of life and mental health. The PROMIS score is a standardized test for people living with chronic conditions. The rare disease community scored lower in terms of their quality of life and their mental health than other patient communities with chronic conditions. So something about that rare disease journey is even more of a burden over and above dealing with a chronic condition.
That's right. And the PROMIS is a patient reported, right? So it's going to ask you, it's assessing what are your perspectives, what are your feelings, what is the impact on you, and that way. And those are important. So sometimes we minimize, sometimes it feels like we're getting a stack of papers, and as someone with a rare condition, that's not unusual. But it's important that we do fill those out, because while we have these research gaps, all that we currently have right now that we can pull from are those assessments, right? That at least substantiates this concern. I often say no data, no dollars, no research, no cure, right? And in the rare community, it's no research, sometimes no diagnosis, right? You can't even get to a cure if you don't first have a diagnosis. So, it's also helping people to understand the value of participating in surveys, participating in data collection efforts, participating even in clinical trials to ensure that there's representation. So I can appreciate that. The other piece that I would say to the person that asked that question is that we're making noise. Right? We are ensuring that we are being seen. We are ensuring that there is representation at all levels, from community to legislation and everything in between, including the hospital systems. As we begin to increase our representation and demand that we are seen, now we can begin to address the underlying barriers that are keeping people from being able to access that care. As we talked about, access isn't just about, there's a hospital 3 blocks away. Well, your access is just fine. Access to novel treatments, access to, medical research, access to that coordinated care. There's nothing worse than having, 3 or 4 different doctors in different systems on different sides, of the state, and sometimes 1 or 2 even being out of state. That's burdensome, and it adds to really the overwhelming capacity issues that we see in families who are dealing with chronic conditions, rare conditions, those things that are not they're not the popular ones that are being talked about. And there's nothing wrong with those popular ones that are being talked about. That's not to say do less for them. It's so you can do more for us. And let's make sure that everyone has what they need. Let's make sure that those who need to play catch up in the medical system are able to do so, and that they don't feel like they're a burden to the system, but that they are embraced by the system. So, I agree, as a caregiver of a young adult, well, he's 27. Is that still considered young adult? I would say yes.
We're all young adults, right?
I would definitely.
I'm a young adult.
Yes. Yeah. Are you still asking me for money? Young adult. Okay. It's really important that we get the community involved. right? To make sure that as we continue to make noise, as we have that Rare Advocacy Day, as we are looking at being at, the Minnesota State Fair and increasing that visibility, we want representation also from a wide variety, from a diverse population of the rare community, so that others who are kind of on the fringe, who are standing back, can feel like that they belong, right? Belonging is a big, huge issue. So that kind of takes us down diversity, right? The representation of rare is not as diverse as it should be. Right. And it's not because they aren't out there. It's because, is there a sense of belonging? Are we opening the doors to say, hey, this is not about any one condition. This is not about any one, socioeconomic community. This is not about just, one primary ethnicity. This is about a larger community that we are fighting together to change the trajectory of our lives. And to do so, requires that we come together. So the more opportunity that we have to come together in this state, that's what I'm really looking forward to. And I'm excited about the RDAC, because I think that through the RDAC that can happen. We can get out of our silos and really begin to link arms and see some effective change. One of the things that I often get concerned about is what I call echo chamber syndrome. All too often, we end up talking to one another about the same issues that we're all aware of. How do we get that issue outside of our echo chamber, right? That goes back to what I said, that representation, that sense of belonging, and making sure that we're visible and proudly visible, right? We don't have to shrink, right? In order to fit in, we have to make sure that people feel like they can show up as their true, authentic selves, no matter who they are, no matter how rare or common their rare disease is. Everyone deserves to show up in their authenticity.
That's great, Ray. And I'm so glad you mentioned the fair. We're going to be joining another big value of the Rare Disease Advisory Council is partnership and collaboration. So we're going to be joining the wonderful Minnesota Council on Disability, which I cannot say enough good about. And so, in any of you out there who want to get extra support, we know that there's sort of like a Venn diagram, right? So certainly not everyone in the rare community has a disability, but the two communities do overlap. And so the Minnesota Council on Disability will be our partner at the state fair. We're going to be joining them at the state fair, having Rare at the Fair day, and again, to represent our community and just let people know that rare isn't so rare, that we're out there, and some of the same messaging that we talked about here in the town hall, really getting that out to the general community, to the general public, that rare diseases do matter and we represent a significant portion of Minnesotans. So please join us. If you're here, reach out to me again. You can come see us at the fair. We're gonna have some educational material. There may be zebra stripes involved.
It's definitely going to be fun. And that goes a long way in visibility, because and expanding outside of the rare community so that we can bring in the allies. You don't have to have a rare disease to be an ally in this community, to champion the needs of this community. And so we absolutely ask that you share, your involvement with someone else. Bring a buddy. That's always what I always say, bring a buddy. And that's how we grow. But it's necessary that we feel that we're bringing them to something. And that's what the RDAC really has been. I am so grateful that we had this conversation. I'm grateful for the legislative advocacy that's happening. I want the entire rare community to understand that, rare advocacy is not about one condition. It's about how do we change the landscape for everyone. So I think about the network access bill, like that's a huge leap in the right direction, because that was a barrier. Needing to see someone outside of your healthcare system, most oftentimes that expert, or as close you could get to an expert, was in another system.
Yeah.
And that system all too often may have been further away, so being able to see someone within your network of your insurance is a huge, I think that it's going to increase the number of the access to specialty providers, right? Because this is a comprehensive approach. This isn't any one doctor, but we have to make sure that we provide, that we encourage all of the medical community to be conversating with one another. So I'm excited about you called it the directory, the provider directory, not registry.
Yes. I made the same mistake for months, Ray, registry, but then some of the clinicians on the council said, just call it a directory.
I get it. And it makes all the sense in the world. Come on, we want any more questions that you might have. And if you represent a rare community, would you drop that in the chat? We would love to see you. We want to acknowledge you. We don't have to say your name, but we will say the condition out loud, because we want people to know that rare diversity is in every room. Rare diversity, we're talking about 10,000 different rare conditions, right? They're throughout your day. If you leave your house, chances are you have probably walked by, rubbed shoulders with, had a conversation with, worked with, had water cooler chats with someone who's affected by a rare disease. I want you to think about that for a moment, because, it's not always out loud. It's not always that that the person is dealing with that. There are rare conditions that make themselves very obvious, and there are rare conditions that don't. But it's important that we recognize that every encounter could be someone who is impacted by, your allyship, by your advocacy, by your voice. And so it is important that we take into consideration that not everybody has a common condition. Some people have a rare condition, and like you said earlier, I get why they say, look for horses and not zebras. I understand that. But I think that if that doesn't include a disclaimer, and not just a sentence, right? But an entire conversation about how do we differentiate, someone who's coming in and complaining of symptoms or something that seems uncommon, it could actually be something more.
One fun thing that I've done sometime, and maybe anybody listening to this could try to throw something out, how could we reimagine that phrase, right? So the phrase is, when you hear hoofbeats, look for horses and not zebras. Is there a way to end that phrase differently, right? So, when you hear hoofbeats, what should that phrase be? How should we end that? That's really my dream, that the medical community would reimagine that phrase.
I agree, because guess what? I mean, horses and zebras travel together, right? But their trot sounds different. And so you have to have to be listening to the trot and not just looking at the stripes or the lack of stripes, right? There are those that we have to look for horses and zebras.
Yes,
that's exactly right. That's exactly right. And so I just think it's wonderful. I know that in attendance, we have some really, really staunch advocates in the rare disease community. So I thank those of you who are attending tonight. I know that we have patients and providers alike. We have researchers, and that's incredibly important. We are all the community. I say it when I'm speaking with the sickle cell community. Community is not just patients and caregivers. Community is all who have impact in improving the outcomes. Because I would rather be linking arms with the person who's in the house helping me to put out the fire than the person on the outside saying, "Oh, the house is on fire. What do we do?" You have an entirely different response when you're in the house with the fire. And now it's, what can we do for us and not just for them? And we have to create this community that is that goes beyond that considers that providers, healthcare workers, those who care about the outcomes of the rare community are part of the community. We may have villages, based on what our diagnosis is and who our persons are, but at the end of the day, we are one big community. So I hope that if you got nothing else out of tonight's conversation, that it's understood that this is not about any one condition. This is about a broader community. Those of you who might watch this on demand at a later time, we want to know who you are. I know that the Minnesota RDAC wants to know who you are, even if you're reaching out just to identify yourself, to say, hey, my name is this and I have this condition and I don't know anyone else in my state, or I don't know anyone in my circle. It's okay. I think that's where we open the gate and we ensure that we create a path for people to come in and be seen, right? That's so
right.
important.
And Ray, one thing that I also have been struck with is, within the rare disease community, different patient groups, sometimes I get so focused on the needs and the continued needs that I also want to call out some of the ways that different patient communities are doing a great job for themselves and leading the way. I know the sickle cell community, you all are doing some really exciting stuff. You mentioned at the beginning, the sickle cell surveillance grant, the work that you're doing to really characterize the journey of sickle cell and where the gaps are, and your community is really leading the way in terms of data collection, using some of the data, the claims data to say what's the behavior of our community, where are they accessing care, where are the gaps, how is care being utilized. And so some rare disease communities can lead the way and provide models for other rare disease communities.
I totally agree, because I think that sometimes we can get caught up in only seeing all of the things we need to do, but I am a firm believer that we also have to measure the progress. So even though the sickle cell community has a number of fires that we need to address, the reality is that this data collection is really paving the way for other conditions, rare conditions, especially with little or much less attention. How do they get the data for those conditions as well? I would say even in new pharmaceutical approaches, we're talking about bone marrow transplant. Now we're at gene therapy. What are the other conditions? You said that they're genetic. So many of them are genetic in nature. So, I don't know how many people know it, but sickle cell disease was the first molecular disease ever identified, right? So it unlocked and unleashed this understanding, and you pair that with the Human Genome Project, and you learn so much. And that's when we saw this advancement, also alongside the Orphan Drug Act, right? Those are important advancements that we have to pay attention to, because they are literally they're the quantum leap into that much closer to diagnoses. So there's lots of work to be done, but we celebrate the progress that's being made. And I celebrate those in the sickle cell community, our organization included, who are on the front lines of some of this. Sickle cell disease is the most common genetic blood condition on newborn screening, but more importantly, it's the most common blood disorder in the world. And that's not a known fact, that we have to make sure that we are helping people to recognize all rare conditions so that the reality of their prevalence doesn't get lost on the fact that they're rare.
That's so well said, Ray. And that's another area you mentioned that I want to call out too, just the great work that the sickle cell community has done in newborn screening, because that's another huge, when we talk about drastically shortening the delay to diagnosis, we know that newborn screening is absolutely an area of priority for the rare disease community. And I know, Ray, you're really working to address some of that follow-up care, right? So you screen these babies, and then the follow-up care, what good is it to screen a condition if people are lost to follow-up?
Right.
I will say that to note that was the lack of being able to access a specialist within network was one of the things that was cited in the adrenal leukodystrophy community as a likely factor to the loss to follow-up. Yeah. So again, another shout out for the state of Minnesota being the first state to really address that issue. But again, you know, the sickle cell community really being a model in some ways oh, we have someone from California. Hello.
Got a couple.
Pass a bill in your state.
I love it. I love it. Yeah. So this, you know, I'm excited because I actually think that the next big movement in the rare community is for the rare community to come together and to show just how diverse we are and just how much we represent, you know, this broader society. We're a society in and of itself, right? But that visibility will greatly improve as we continue to work together as a community. I want to be mindful of everyone's time. So I want to make sure that I say once again, thank you so much for joining. Before you drop off, please don't drop off quite yet because I have my announcements at the end. And are you all seeing that? Yes. All right. So just a reminder, give it about 24 to 48 hours and we will have this recording uploaded to our YouTube channel. As you can see, you can use our bit.ly link, or you can just go to YouTube and put in SickleCellMN. I really want to thank our special guest, Miss Erica Barnes. I am so grateful for the work that you are doing. The community is better because you're in it. And you know, it's hard when it comes because of a loss. And there's nothing easy about that. But that turning that pain into purpose and ensuring that other people can benefit from that purpose is, I think, something that you and I really have in common. And there's many of us out there that do. So if you are looking to get in touch with Miss Erica Barnes, you can go to the website, as we've already said, MN Rare Disease, so MinnesotaRareDisease.org. Is it .org or .com?
.org.
Oh, it is. Okay. So the link I put in the chat, ignore that. It said .com. On Facebook, you can look it up by Minnesota Rare Disease Advisory Council. And then on Twitter, RDAC, RDAC. And at LinkedIn, you can look up at Erica Barnes and you can find her there. Now, as far as Sickle Cell Foundation of Minnesota goes, this is a rendition of our education program, Sickle Smart Sessions. You can go to our Eventbrite page and you can actually follow us on Eventbrite in order to know when we are having more live sessions. We would love that. You can also find it on our social media. We always update that multiple times as a reminder. We are always SickleCellMN everywhere. At least that's the goal. As I said before, our YouTube channel is literally a repository of education. That we have, you know, dozens of videos that we have done over the last couple of years that'll help keep you smart. And if you have sickle cell, you can be sickle smart, but you can be rare smart too, right? And so we encourage you to take a look on our YouTube channel. Our virtual activities that we have monthly and quarterly, we have a monthly sickle cell support and empowerment group. And we are I won't let the cat out of the bag too much, but we need a rare support group. We also have an Ask Dr. Nelson. That is another form of town hall that is really coming from a healthcare provider in the sickle cell space who who cared for sickle cell disease for 30 years and is now retired. But he comes from the inside out to tell us how to navigate, but also to acknowledge some of the challenges that really do exist within healthcare and identify solutions for that. He's also our medical director here at Sickle Cell Foundation of Minnesota. So Dr. Steve Nelson, some of you may know him. And then one of my favorites that we just launched this year, More Than Our Sickle Cell. Sometimes we find ourselves feeling like our entire identity is our diagnoses. And that is part of who you are, but it is not all of who you are. We don't want you to get lost in thinking that you are only your condition. You are more than your condition. So we want to talk with people about just their existence, right? Their lived experience, not just in the disease, but just navigating society and navigating other needs that you may have in your health. So join us for that. Our next session is in September. We just had one. Now, this is something that you all may want to join us for. Race, Racism, and Health Equity. We are being joined by Dr. Nathan Chomolo. He is the pediatrician and internist, but he's also the Medicaid medical director. And we're going to have a frank conversation with him. And we are going to talk about, we're going to say the quiet things out loud. If you know Ray, those are the things I like to have. I like to have those kind of conversations. And so you can go to our Eventbrite channel to sign up for that. You can also check out our calendar on our website to stay up to date with other sessions that we have coming up. I never leave this platform without reminding people that donated blood saves life. It does not, the donated blood isn't just sitting there. It's actually going to save life. It's not making products, it's saving people. And if you are in the rare disease community, you may have some unique characteristics about your blood, and encourage your family and friends. Encourage those, who come from similar ethnicities. We need donor diversity in order to make sure that the right product at the right time for the right person is available. So, and then for some people, a bone marrow transplant is the answer. And so we do have Be the Match is right in our backyard. They are based here in Minnesota, even though they are global. So we encourage you to sign up for the registry. And when you're on the registry, you also can save a life. So that's very important. Last but not least, we have set up a platform that allows people to tell us about their experiences navigating the healthcare system. It is not about any one condition. It is not about any one hospital system. We want to know the good and the not so good. We want to make sure that when we are sitting at the table and we are representing all of these different conditions, that we can speak to the lived experience that has been shared with us. We don't share your name, don't worry, but it is important that that you let us know what's happening in your world. And then where there's advocacy possibilities, we want to make sure that we show up for that, or at least point you in the right direction to get the advocacy that you need. All right. Well, last but not least, once again, I want to say thank you to those of you who came and those of you who stayed all the way to the end. Woo! I do appreciate that. Thank you so much, and we'll see you next time on Living Sickle Smart.